To the MCSTAP webinar. This is February 2025. I'm going to share our screens in a second. Give me 1 second. All right. All right. And can you see the slide deck?
Yes.
Okay, good.
We can.
So
yes.
Great. So today we're going to be talking about smoking cessation. Dr. Mia Sorcinelli Smith, who is out of you're out of Greater Lawrence, right?
Correct.
At Greater Lawrence Community Health Center. She is affiliated faculty at Tufts and UMass Medical School, and she's going to be talking about smoking cessation. Let me just tell you a little bit about MCSTAP. If you're new to MCSTAP, I'll very briefly orient you to it. So MCSTAP is the Massachusetts Consultation Service for the Treatment of Addiction and Pain. That's our phone number, and that's our website. If you want to reach us, you can use those numbers. What do? We provide support to clinicians to help them increase their capacity and comfort using evidence-based practices to screen, diagnose, treat, and manage the care of patients with chronic pain or SUD. We provide real-time, curbside phone consultations to all clinicians across the state. MD, NP, PA, doesn't matter. If you're taking care of a patient who has SUD or chronic pain and you're using opioid medications to treat them or just have general questions on management, you can contact us and we will reach back to you within 15 to 30 minutes and provide you some expert consultation. We also have information on local resources for referral if necessary. All referrals are free of charge. What kind of things do we help people with? Well, for example, we provide personalized real-time coaching on the initial as well as follow-up consultations for your patients wherever they are in their care. We can provide, let's see, what else? Next slide. So hold on. And then here we go. Because I'm not in presenter mode, I can't show it correctly. But anyway, we also, in addition to providing consultative services, we also have a monthly webinar, which you're going to be hearing about smoking cessation today, as well as we provide in-depth mentoring services. So, for example, if you're inheriting a large practice of patients, or you have a bunch of patients that are chronic opioids or have lots of SUD, and you're feeling overwhelmed, or you're feeling that you need to improve their care, or perhaps you're transferring their care, receiving, or going to be delivering, and you'd like to go over them in detail, we can provide a weekly session with one of our consultants to help you go over those cases, each of your patients, and help you figure out what needs to be done for them for the future. Usually it's over a course of 12 weeks. Again, it's free of charge, and people find that it can be extremely helpful. Our team consists of 10 clinicians across the state. They all have expertise in treating chronic pain and SUD. They all are experienced teachers and mentors for providers, and they're all deeply committed not only to taking care of patients, because they really do take care of patients. They're not just talkers, they're doers, but they're also deeply committed to you and to helping you do a better job so you can help your patients. I'll finally just mention just some house rules. We are, this is, if you're new to the webinar, we run a kind of an open discussion group. We like people to ask as many questions as possible. Our goal is to foster a safe and interactive learning environment. So please treat each other with respect. When listening, please turn on your video to enhance the group's interaction. Please mute your video unless you choose to speak. And place your questions in the chat addressed to everybody if you choose not to use your voice. To speak, please raise your hand and don't use the names of patients, colleagues, or others while you're discussing. All questions are welcome. Remember, the question that you might be asking but are afraid to might be a question that 3 other people would love the answer to. So please don't hesitate. With that, I'm going to turn it over to Dr. Sorcinelli. Let me bring her slides up and she can introduce herself while I'm doing that.
Hi, everybody. My name is Mia Sorcinelli, and I'm a family doctor, and I'm also board certified in addiction medicine. I work at the Greater Lawrence Family Health Center as a family doctor, and I run our Suboxone, Vivitrol, and Sublocade program. And then I also work for MCSTAP 1 day a week, Tuesday mornings, and I work 1 day a week as a program physician at a methadone clinic, Spectrum Methadone Clinic in Saugus. And I love smoking cessation. So we were looking for great topics for webinars this year. And I said, well, what about smoking cessation? Because it's such, I don't know, bread and butter, primary care stuff that I think sometimes there are tips and tricks that maybe we didn't know. So Chris, you could do the next slide.
Can you see it?
No.
No.
I can still see the first slide.
All right, hold on. Sorry. I seem to be having problems today. I don't know why. All right, I'm going to stop sharing. I'm going to start sharing. And then I'm going to pick the right one. And hopefully this is it. How's that?
I can still just see the beginning slide. There we go. Thanks. So we'll just review a little bit of the epidemiology of like scope of tobacco use, a little bit about the history, cultural significance that I think is kind of interesting, but maybe not all that clinically relevant. We'll talk a bit about the nicotine neurobiochemistry, which I know makes some people cringe, but it is helpful to understand the mechanism of action of some of these medications that we can offer patients. We'll go over the pharmacologic options and sort of which ones are better or worse, how to combine them together. In my abundant spare time, I also really like helping people use our EMR more effectively. So we have Athena at Greater Lawrence. And so I just have a couple little tips of things that we've done in our clinic to try to group some of these scripts together that I think are helpful for people if you're in a busy visit and you're trying to address a bunch of things. And then we have a couple cases at the end just to kind of think through a stepwise approach for some patients that maybe are a little more complicated. Can you do the next slide, Chris? I also apologize in advance. I'm like recovering from this sinus thing. So if I cough, I'm sorry. So whenever I talk to our residents, we have a residency program, family medicine residency at Lawrence, and I give this talk with the residents too. So I always say to them, what is the most deadly addictive substance in the world? And, they guess alcohol or fentanyl or cocaine. It's actually tobacco, mostly through smoked cigarettes. So worldwide, tobacco use causes more than 7 million deaths a year. 7 million is a lot. And if it stays the same, more than 8 million people a year will die from diseases related to tobacco by 2030, so worldwide. And then in the United States, again, mostly we're talking smoked cigarette tobacco. It remains the leading cause of preventable disease and death in the US. So 2022 is the most updated data that I found. About 49.2 million, 1 in 5 adults reported current tobacco product use. And every year, about 480,000 deaths in the US are attributable to cigarette smoking. Next slide. I think, this is say products. So I think we know, if you're a family doctor, you're a pediatrician and you're working with teens in any capacity, a lot of our teens are using different products. So not all teens are smoking cigarettes. It's actually kind of a smaller number, 1.4%. A lot more teens are smoking e-cigarettes or using those nicotine pouches, and then you can see it goes down from there. So just something to be aware of. Young adults and teens, when you're talking about cessation, with adults, it's much more often the smoked cigarettes, but with teens, just be mindful to, ask about e-cigarette use as well. So, cigarettes are awful, and we as doctors, I really think that we should be talking to our patients about quitting at every visit if they're smokers. I found this data and I thought it was pretty telling. And I know we're busy, I'm busy, I'm a family doctor, I get it. Only half of adults who smoked, who went to see a doctor in the last year or another healthcare professional, received advice or assistance to quit. So that means, we, the royal we, we're missing about half of our opportunities to ask patients about it and to offer them treatment. And I'm often really surprised how open patients are to making a change when I ask them. So I try to ask everybody at every visit, and sometimes they'll, for months and months, they'll say, no, 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 no. And then they'll say, well, okay, maybe I'll try the patch today. And so, it really is a matter of like repetitiveness with a lot of our patients. So in 2022, there was this study, only 50.5%. Oops, I lost the slides, Chris. Can't see them. Did everybody else lose the slides?
Yeah.
Sorry, I don't know if I like touched something. Okay, I can see them now. And then only, 49.2% of patients received assistance, whether that was advice about quitting or a prescription to quit. So even a very brief statement to patients, less than 3 minutes, hey, I'm really worried about your smoking. I really think you should quit. Even just that improves the chance of quitting, and it's cost effective because it's free basically. And then less than 4 out of 10 adults who do smoke cigarettes used proven treatment. So either counseling or medication. And I really lean heavily on medication because a lot of patients don't have time or insurance coverage for counseling. But so, 40% received evidence-based treatment when they're trying to quit. Next slide. Cigarettes are also the worst because tobacco companies make a ton of money off of them. And, this money is coming out of our patients' pockets. The largest tobacco companies, I found this shocking, spent $8.6 billion marketing cigarettes and smokeless tobacco. And this is just in the United States. And so that's about $1 million an hour marketing cigarettes or smokeless tobacco products. You think they could probably do something else with that money, but next slide. Cigarettes, tobacco is not an equal opportunity killer. So smoking does disproportionately affect folks that are, more in need, sort of poor, homeless patients, racial minority, LGBTQ patients, anyone suffering from mental illness, substance use disorders, any of us who take care of patients on Suboxone, we know so many of those patients are also cigarette smokers. There are up to 10 times more tobacco ads in Black neighborhoods than in other neighborhoods. So, this is an issue that really, it crosses economic lines, but it's not distributed equitably. So it's something to be mindful of if you're in this business with like an equity lens, really ensuring that you're talking to all patients and maybe even focusing on the patients mentioned in this slide, to try to assist them to quit. Next slide. So if you're like a history buff, this is kind of interesting. So tobacco has been used for a long time. It was used early in recorded history and even before then. In North America, it was really first used by indigenous peoples prior to European colonization. It really wasn't used every day. It was more of a ceremonial thing. There's an article here that I put in just because I thought it was kind of interesting about the archaeologic record that they found evidence of tobacco use way back in the day, but it definitely wasn't a mainstream product that was widely distributed. Next slide. So what really changed was, the Industrial Revolution and mass production of cigarettes, which again, I think this is kind of interesting. So there was the machine that was in 1880, the Bonsack machine. It could roll 210 cigarettes a minute. Prior to that, they were hand-rolled cigarettes. And now we have machines that can roll 20,000 cigarettes per minute. So that's 1,000 packs a minute of cigarettes that can be made, which is a lot. Next slide.
Mia, can I throw a piece of history in there as well?
Yeah, of course.
So smoking tobacco in paper, i.e. a cigarette, was not invented until the Crimean War, which was in the late 1800s. Prior to that, most Europeans smoked tobacco through a pipe or in a cigar. But the Turks used paper and rolled it, and because it was an international war, the British picked up on that, and they brought it back to England, and that's how paper cigarettes actually made it back to the United States, because that's not how people in the US used to smoke it originally. So it was basically the Crimean War is what popularized the cigarette.
Fascinating and disappointing. If only we had stopped with the pipe.
Absolutely.
All right, so we'll talk a little bit about tobacco, nicotine and the brain. Again, this is like med school level stuff, but I think it's helpful. So when you're smoking a cigarette and you inhale that smoke, the action of the combustion of the tobacco kind of distills the nicotine, and the smoke carries the nicotine into your lungs, where it's very rapidly absorbed into your venous circulation. The peak blood level is about 6 to 10 minutes after the first inhalation. And then nicotine enters your arteries, it moves quickly from the lungs to the brain, and in the brain, it binds these nicotinic cholinergic receptors. And if you remember back to biochemistry, a lot of the receptors in our brain, they bind something and they open up a channel and they allow sodium often or calcium to go through the channel. And, I'm sure you can all remember those diagrams that we studied with the little receptors in the cell membrane. And so the downstream effect inside your cells in the brain is release of neurotransmitters. You can do the next slide. No, it's 2 slides up from where you are. One more up. Yeah. So this is just a little tiny picture of the brain with the receptor. And so it releases a variety of neurotransmitters, but if those of us who work in addiction care, we know that dopamine is one of the neurotransmitters that's very commonly implicated in a lot of diseases of addiction. And so dopamine is sort of a pleasure neurotransmitter, and it really reinforces, it sort of develops these pathways over time that reinforce the effect and sort of the craving and the ongoing use. And it's the same for opiates, it's the same for a lot of our other substances. So the first cigarette of the day, I find this to be really interesting, and when you talk to patients about it, this certainly holds true with their experience. The first cigarette of the day is kind of the most wonderful cigarette of the day for the patient who's smoking, and they feel the most substantial effect. And then interestingly, at the same time, this very rapid tolerance to nicotine begins to develop in the body. And then with each cigarette that's smoked throughout the day, there's an accumulation of nicotine in the body. And so the tolerance level, this little graph I love, the tolerance level is going up. The pleasure from each cigarette is sort of less and less. So you can see the graph is kind of tiny on my screen, but you can see off to the right, it says pleasure or arousal. And then that gray zone is sort of the neutral zone where you're just feeling okay, you're not feeling great, you're not feeling bad. And then below the curve is the withdrawal symptoms. So the threshold for feeling okay goes up and up throughout the day, and the threshold for feeling the pleasurable effects of the nicotine also goes up throughout the day. The other thing that I think is really interesting about this graph is if you look, you can see the time it takes to kind of drop down into the withdrawal zone and go back up. If you count those peaks on the curve, there are 20 peaks on the curve, and there are 20 cigarettes in a pack of cigarettes. So it's not a coincidence that 20 is the number, and that many patients, when we ask them how much they're smoking, many people are smoking 1 pack a day or 20 cigarettes a day because of the timing of those peaks. So it goes, they go up and down throughout the waking day. Then when the patient goes to sleep, they're not smoking at night, or many people don't smoke at night, and the levels drop back down, kind of resets that tolerance, and then they wake up in the morning and they have that first great cigarette of the day again, and then they spend the rest of the day kind of chasing that great feeling. And again, for those of us who, we work with patients who are using other substances of abuse, this is a very familiar story that we hear. Patients will say all the time, well, I don't even use to get high anymore when they're talking about opiates. I just used to feel normal. That's kind of how it is with patients who smoke cigarettes. They're really smoking throughout the day to feel normal, not to feel great. All right, next slide. Any questions about any of that stuff? That all sound kind of familiar, comforting, disturbing, I don't know. All right, next slide after pharmacotherapy. All right, so this is an audience participation. Maybe you can put it in the chat, or if you want to unmute. So there are 4 types of nicotine replacement medications that are currently available in the United States. And bonus points if you know there's a 5th one that's no longer available in the United States. So I don't know if people want to type it or shout it out. Someone's raising their hand. I think you can just unmute, Anne, if you want.
Yes. Yeah, you've got the patches, you've got the lozenges. The one that's no longer available is the inhaler, and then gum, and then I don't know what the 4th one is.
There's one more, very good. There's one other one. It's not all that commonly used, I would say. I don't know if anyone else wants to take a shot at it. If not, it's like a little
the
nicotine
nasal spray.
Yes, it's the nasal spray. Very good. I'm not sure who that is, but yes, excellent. All right, next slide.
Huh, good question. All right.
All right, so
this is the next slide.
Yeah, next slide. And then, so the Nicotrol inhaler, unfortunately, is discontinued. I had a lot of patients who actually really loved that. It was like this little tiny white thing that you could, inhale. It was prescription, FDA approved. We knew what was in it. Apparently the binding compound that they use to affix the nicotine to the thing inside the inhaler is no longer in production, and that's why they had to stop making it. So that's too bad. All right, next slide. So nicotine patch, we're just going to go through them kind of quickly. People may know this, they may not know everything that I talk about. So it's a steady dose of nicotine that's there for 24 hours. It's available over the counter. Some insurances do cover it. I often write prescriptions for it because I can't always keep track of whose insurance covers it, and it's just easier. Sorry, Chris, can you go back to the first nicotine patch slide? Thanks. And in randomized controlled trials, patches have been shown to be 2 times as effective as placebo. Heavier smokers may need higher doses, and you can go pretty high with the dose. So it's been studied up to 3 patches on at a time. So you go next slide, please. And how do you know what dose to give people? There are lab tests that you can order, but it's really hard to order that lab. It's more of a research lab. What most people do, and probably what you all are doing, is base it on the number of cigarettes that someone's smoking a day. So if they're smoking a quarter of a pack a day, 7 milligram patch, half a pack, 14 milligram patch, 1 pack a day is the 21, and then 2 packs a day is 2 21 milligram patches, and 3 packs a day is 3 21 milligram patches, which 3 packs a day is 60 cigarettes a day, which is a real commitment to smoking. I have not met many people who smoke 3 packs a day, but I definitely have patients who smoke 2 packs a day. So don't forget that you can give them extra patches to help them. And, patients always ask, well, can I smoke when I have the patch on? And I think that's a barrier to patients wanting to stick the patch on. They know that they're going to be smoking and they don't want to interrupt. So that's one of the reasons that we'll talk about this in a minute. I really recommend combining the patch with either the gum or the lozenge so that they can stick that patch on and then chew the gum and not have to worry about smoking. They're not supposed to smoke with a patch on. So then there's the nicotine gum, also available over the counter. I also write prescriptions for this all the time. It comes as a 2 and a 4 milligram little chiclet thing. It comes in minty flavors or fruity flavors. This is, I don't know, pineapple, whatever, fruit chill, I think it's called. And how do you decide the different dose? So 4 milligram dose is for people with quote unquote higher dependence. And the way you can judge this is you say to the patient, how long after you get up do you wait until you smoke the first cigarette of the day? And if they wait less than 30 minutes before they are smoking that first cigarette of the day, they should get the 4 milligram dose. And then the real key with the gum is you really have to tell this to patients, because I am constantly surprised how many people don't know that you cannot just chew it like normal gum. If you chew it like normal gum, you'll swallow a lot of the nicotine and it will upset your stomach and you will not feel good. And a lot of people will be like, this isn't working for me because nicotine is not absorbed through your stomach. It's absorbed through your oral mucosa. So they have to chew it and park it. So chew, 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 it starts to taste peppery, and they stick it in between, you know, their lower jaw and their cheek, and kind of let it sit there so that the nicotine is absorbing. You can use it as a monotherapy, but it's much better. Like, the evidence by far supports combining it with the patch. So that, you know, the 21 milligram patch, and then they can chew a ton of nicotine gum throughout the day. Every time they feel like they want a cigarette, you know, 20, 30 pieces of gum a day. And then, you know, work your way down from that. Next. So the lozenge is very similar. The lozenge is available also over the counter. It's a 2 and a 4 milligram. The 4 milligram dose similarly is for those patients with the higher dependence. So if they're smoking their first cigarette right away when they wake up. It's also dissolved, you know, like in your cheek for the same reason. And we want to use it with the patch. And so who would get the lozenge versus the gum? People who don't have teeth. You know, people who have dentures, people who maybe they have really bad dentition, they might prefer the lozenge over the gum. I'm just gonna look. I see some people are putting things in the chat. Okay, let's see. Someone says, do alternate nicotine preparations for the e-cigarette, the pouch, have the same impacts in the brain, speed of onset, dose relationship as inhaled nicotine in cigarettes? That is a great question. So the e-cigarette, because it's the combusted nicotine, yes, my understanding is the rapidity of onset is very similar. The pouch, I do not know. I would have to look it up. And in terms of the dosing, there was a podcast that I was listening to, they talked about this. It is very confusing to figure out the dosing because every e-cigarette product is slightly different. And so it can be hard if you're trying to help a patient quit e-cigarettes with some of these pharmacologic interventions. You might have to experiment a little bit because the milligrams of nicotine that are on the vape liquids aren't always the same as what we would be prescribing them. The resources online from Stanford is a great resource for tobacco equivalents. Thank you, that's a good tip. How often do you see misuse of patches to enable the neurologic effects of nicotine? That's a great question, Sarah. I don't see it all that often, but I don't know if other people do. I probably wouldn't restrict my prescribing of the patches for that reason. I would rather someone misuse the patch than smoke cigarettes, I guess. So, could we do the next slide? The nicotine nasal spray, Nicotrol. So this one is prescription only, 0.5 milligrams per spray. This one is sort of designed to mimic that really rapid onset. It goes right into the nasal mucosa. Patients feel like relief from any sort of withdrawal symptom very rapidly. The most common side effects are kind of like a runny nose and a sore throat, watery eyes. That lasts about a week. So if patients can get through that first week of feeling a little, like they have a cold, again, this is one that I've heard really good feedback from patients if they can make it through that first week, but some people get frustrated and stop using it after a couple days. And then sadly, as we mentioned, the nicotine inhaler is discontinued. Maybe it'll come back someday. So I actually spent a lot of time preparing for this talk, looking to try to find information about, can we advise patients to use e-cigarettes to help them quit cigarettes? And I will say that the data is, I think the jury's still out. People who use e-cigarettes often don't fully stop smoking, according to some of the research that I was looking at. And so, now they're exposed to both. traditional tobacco cigarettes and sort of this vaped e-cigarette liquid stuff that we don't fully know how dangerous it is. In some of the studies, they provided e-cigarettes as part of their study design. And in those studies, like when they gave patients free e-cigarettes and counseling, that was associated with increased quit rates. But when they just observed patients, there was one study where they like gave them either e-cigarettes or a voucher to do with what they wanted. And people were sort of sometimes buying e-cigarettes, but not every day or not consistently. Those people continued to smoke, whereas the people who were provided with free e-cigarettes stopped smoking. And then, oh yeah, sorry, this was that New England, so there's a New England Journal study from I think this year or last year where they did both. They like either gave them the nicotine replacement or e-cigarettes. They did see some quit, but people who are kind of dabbling didn't quit. So, you know, I think anecdotally what I have seen is a lot of my patients who make the switch to e-cigarettes use a lot, they vape a lot, they have a really hard time stopping vaping. And I usually say to them, well, we don't know for sure if it's safe. It's probably better than smoking cigarettes, but there may be long-term issues with the e-cigarettes that we don't really understand yet. And I don't know, I would guess people have kind of similar experiences, but if there's something that you know that I didn't find when I was digging around in PubMed, and feel free to jump in. All right, we can do the next slide. So again, I don't know if anybody wants to write in the chat or not. We have, so that was our nicotine replacement options. And then there's some other prescriptions that we have that are non-nicotine replacement. I don't know if anybody wants to tell me what your favorite one is or your least favorite one, or we can just keep going. Want to do the next slide, Chris? So bupropion is a monocyclic antidepressant. It inhibits norepinephrine and dopamine reuptake. So remember, nicotine is like releasing dopamine, and so bupropion keeps that dopamine kind of around longer so people feel better. It also seems to maybe work on disrupting some of that reward pathway, which may help decrease cravings. So the sustained release formulation is the one that's FDA approved for smoking cessation. And in an ideal world, you would meet with your patient and say, okay, I'm going to prescribe you this bupropion a week before your quit date, and you're going to take one 150 milligram tablet for 3 days, and then you're going to increase it. They could take it for 6 to 12 weeks. As we know, there's some contraindications to bupropion: seizures, head trauma, history of eating disorder. You can do the next slide. And some of the common side effects are insomnia and dry mouth. Patients can take it if they're on other meds for depression, so it can be used with SSRIs, tricyclics. It's not recommended to use if someone's on a monoamine oxidase inhibitor. Next slide. Varenicline is the medication formerly known as Chantix. It's now generic. It is a very cool medication. If you're a Suboxone prescriber like I am, I always say to my Suboxone patients, it's like Suboxone, but for cigarettes. So it binds to those nicotine receptors in your brain. It blocks the nicotine from binding to the receptor, and it stimulates the receptor activity. Sorry, so it's an antagonist and an agonist. It does lead to dopamine release. So, remember that mechanism. It's giving people the good feeling without the cigarettes. It's not really metabolized in the body. And based on data, it generally in trials, it's more effective than placebo and more effective than bupropion. Next slide. We probably all remember that for a while it was off the market because of this nitrosamine contamination. So as of 2022, it's back on the market. And it's generic now. It's very comparable to using combined nicotine replacement therapy, so patches with gum and lozenge compared head to head. It's safe in patients with coronary artery disease, safe in patients with COPD, safe in patients with complex mental health issues. So for a while, there was a black box warning. There was a study where they studied patients with like schizophrenia, bipolar disorder with psychosis, and they kept them on varenicline for 12 months and had no, it was not associated with any worsening of their mental health. The most common side effect is actually nausea. That's why we do that little combo pack. So they start with a lower dose and then they increase. Also very common are weird dreams. I have some patients who love the weird dreams and some patients who really, really dislike the weird dreams and were unable to tolerate varenicline because of some really bad dreams. And this medication also can be started before the quit date. So if someone's kind of waffling and they're not really sure if they want to quit or they, okay, I'll try it, they can just start taking it. They don't have to stop smoking before they start varenicline, which is really nice. Next slide. So initial course is 12 weeks. You can use it up to a year. It's been studied up to a year. There's some new, there was a new article that I saw that I thought was really interesting that supported using a higher dose of varenicline if the first treatment attempt with it was not successful. So the standard daily dose once you get through the starting pack is 2 milligrams a day, but patients can actually take 1 milligram in the morning and 2 milligrams in the afternoon. I have not written a prescription for this yet, so I do not know if it would be easily covered by insurance. I work with a mostly mass health patient population, so I'm always thinking about what does mass health cover, what does it not? So stay tuned. I guess we'll see more. Again, this was end of 2023, I think, that this article came out. And then just a couple medications that are not FDA approved, but have been shown to perhaps be helpful. Nortriptyline is not FDA approved for smoking cessation. It's considered second line because it doesn't have the approval, but there's some data out there that says it's pretty close to bupropion. So if someone does not like bupropion, they might be able to try that. You start 25 milligrams, increase them up to about 100, 12 to 24 weeks. As we know, nortriptyline is sedating and gives people dry mouth. So those are very common side effects. Next slide. Clonidine is also not approved by the FDA for smoking cessation. It's another second line therapy. It's been shown to be effective up to 0.3 milligrams a day. Also causes dry mouth and sedation. So be aware. And then, I think I added an extra slide that maybe isn't in this deck. So there's another medication out there called cystazine. It's not available in the United States. It's pharmacologically similar to varenicline and has been shown to be pretty effective outside of the US. So it'll be interesting to see if in the next couple of years it comes to the US as another option. Stay tuned. And I would say I tend to lean heavily on pharmacology for patients who want to quit. I love combo of things. So I really almost never give the nicotine patch alone. I always really counsel people to use it with the lozenge or the gum. Bupropion can be used with the inhaler. It's better than either one alone. Bupropion with the nicotine inhaler, or, I guess now maybe we do the nasal spray and the patch, it doubles abstinence rate. You can use varenicline and nicotine replacement therapy. It's superior to varenicline alone. And you can combine varenicline with bupropion if you want. They have different mechanisms of action and they can work together. Next slide. So again, this is my handiwork here. I fancy myself an Athena, expert. And so we made these little order sets so that if a person who's not obsessed with smoking cessation the way I am is seeing their patients and they're like, oh, I remember I should do, the patch and the gum together. They can search in our EMR for tobacco, and there's these little handy groupings that already have like the doses and kind of a little explanation. So if any of you are EMR dabblers in your spare time or have the ear of your local friendly EMR person, we've found this really helpful, again, for people who aren't doing it like every day, kind of the way that I am. to make it more accessible to PCPs in their regular office visits. Any questions or comments? I want to be mindful of time, but I have just like 2 kind of short cases.
This is
Sarah,
Chris.
Hi.
Oh, sorry. There's one question in the chat, Chris, that I think is really great. What methodologies do you find effective for maintenance of abstinence after the initial course of pharmacotherapy? Sarah, it's a great question. I have patients who have continued to use the patches for months after they quit, because they just, I don't know if it's like that safety, seatbelt kind of thing. Like I know I don't want to smoke, but I'm going to put a patch on every day. They can continue to use the gum and the lozenge if they want. I think a lot of like celebration, celebrating when patients quit, asking, again, I try to ask about it often. And so if I know someone has quit, I'll just be like, oh yeah, remind me, when did you quit smoking? Oh my gosh, it's so great that you quit smoking. I'm so glad that you quit smoking. But you can continue to use some of the pharmacotherapy. And, again, the bupropion, patients can take that, continue to take it. Varenicline, they can take for up to a year. Not everybody wants to take it for that long, but some people might find it helpful. Chris, I don't know if you had something you wanted to say.
I did, but it escaped me. So.
Can you do the first case?
Sure. Oh, I know what I was going to say. And I think I've said this in the past. Smoking cessation, or should I say tobacco smoking, is a stigmatized behavior.
Mm.
But it's not as stigmatized as some of the other substances we deal with. So it's a little bit easier to talk to people about quitting smoking than it is talking about other substances. I don't know why. It's just not as socially difficult. And the reason I point that out is it sometimes is very difficult to kind of get past your feelings when you're dealing with patients that are using opioids, for example, which are illicit substances in some situations. It's nice to be able to practice the language and the behavior of helping people quit smoking using non-judgmental language. And I would argue it's a little easier to do that with tobacco, just because it's a little less stigmatized. And so I like to think about every time I do counseling, cigarette or tobacco cessation counseling, I think of it as practice for talking for my really tough patients that have opioids or alcohol or other illicit substances where I may be struggling more with stigma. It's a great way to kind of practice the language with a little less stress involved because of the stigma. And so I like to point that out to people. It's great practice.
Yeah, and I think, as a primary care doctor, there probably isn't much else that I can do for somebody's health. Helping someone quit smoking is probably one of the most impactful things that I can do for their future health, right? If I can get somebody to quit when they're 35 instead of continuing to smoke until they're 70, just the improvement in their overall health over the next 20 years is going to be amazing. So I think
plus their quality of life too.
Yeah, plus to save so much money. I mean, there's just a lot of benefit, a lot of good feeling coming out of helping people quit smoking.
I think that's really important to point that out because let's be honest, tobacco counseling can be somewhat pedestrian, but when you think about the impact that this has, it's unbelievable. Of all the things that we do, if all I did was get people to quit smoking and never treated diabetes or hypertension, my guess is I would probably be improving the health of the population better.
Right.
Anyway.
You'd save their lives. Catherine put a question in the chat. This is a great question too. I've had patients not want to try bupropion or varenicline due to concerns about reading about the suicidal ideation risk. How do you counsel to ease this concern? So usually what I say to patients is I've never actually had a patient stop varenicline or bupropion for suicidal ideation. And the patients that I've had stop the medication have been few, actually, very few. And one in particular was one of my patients who had just a very horrible, it was almost like a waking hallucination kind of dream while they were taking varenicline. And that happened really soon after they started the prescription, maybe in the first week. I mean, they had only taken a few doses, and then they had this very vivid, distressing dream. And then they like never have wanted to take it again. Fair enough.
Get me out of here.
Yeah, I mean, so I do bring it up to patients. I talk about the side effects. I usually tell them that if you're going to notice the side effects, again, this has been my experience, that they are pretty prompt to appear, and that they should just, stop the medication, call the office, let us know if they're having any of those side effects. But I prescribe a lot of varenicline, and I actually, knock on wood, so far have not had anybody with suicidal ideation from taking it. I prescribe less bupropion, but I also haven't had anyone with that. So I do find if I say to patients, like, I've never had a patient, even though I know it's like such anecdotal nonsense, but I do think patients find it comforting if you're like, I've never seen it, but let's keep an eye on it. Just stay in touch with me. And again, for me, the vast majority of my smoking patients are also my Suboxone patients. And so those are generally patients that I'm seeing more frequently, perhaps, than I would be seeing my other patients, just, for the timing of their refills. And so I know that I'll be checking in with them pretty regularly about any side effects that they're having.
Okay.
Oh, great question, Sarah. Hold that thought. Hold that thought. So let's do, we don't have a ton of time, and I know I have patients waiting for me, so we'll do these cases kind of quickly. So there's a 45-year-old patient who has a past medical history of obesity, diabetes, hypertension. They smoke 2 packs a day. They were recently admitted to the hospital for chest pain. They were ruled out for a myocardial infarction, but it kind of scared them, and now they're ready to consider smoking cessation. They've never tried any medications. Can you do the next slide, Chris? Oh, sorry. Go back up to the first one. What would our first, like, what would people think would be a great first option for this patient? Never tried anything. They're super motivated. They want all the things. Go for it, Anne. You don't have to raise your hand. You can just unmute.
Well, I mean, the easy thing is just nicotine replacement, right? Because they're already smoking, so you're not changing anything. But I know the big message here is nicotine replacement with medicines is going to lead to more success.
Correct, right. And so I would say too, it's the combined nicotine replacement. So making sure it's not just the patches, but the patches and the gum. And then for this person, they're smoking 2 packs a day, so they might need the 2 21 milligram patches, and they would probably need the high dose of the gum or the lozenge. Any other thoughts about medication? Like, say they said, oh, I don't want the patches because, I don't know, my mom tried them and she didn't like them. What would your other kind of first line option be?
Well, you could do the Chantix. Sorry, I don't know the generic, or the bupropion.
Yeah. Right.
So
and I would say,
one of my favorite stories from primary care, and this is like 20 years ago, was when I started someone on bupropion for that. And it was so funny. He came back for his follow-up. He was in his 40s. He's like, yeah, I didn't stop smoking, but you're not taking me off of that. I was like, oh, we have some undiagnosed depression going on.
Okay, you can keep it. Yeah, right. So the varenicline, I think, is slightly more effective than bupropion, but certainly if you think someone has underlying depression, that you may lean on the bupropion. All right, can we do the next slide? All right, so let's say this is the same person, but they already tried varenicline once and it worked okay, but then they started smoking again. What could we do? So, we could increase the varenicline dose. So you could do 1 in the morning and 2 milligrams in the afternoon. You could have them try varenicline again with combined nicotine replacement therapy. They're smoking so much that they might just need more help. And then Sarah's great question of what other, what other testing might we want to be thinking about in a 45-year-old with a, 40 pack year smoking history. Is the low dose lung CT for lung cancer screening. I believe that Mass Health covers it at age 50. You perhaps could get this patient covered because they have such a long smoking history. Generally, it's someone 50 and over with a 20 pack year history who has no symptoms of lung cancer and is either currently smoking or has quit in the last 15 years. Those are the folks that qualify for it. And so, a lot of my patients will bite for this one because I usually say to them, 10 years ago, honestly, it probably wouldn't have mattered if we knew that you had lung cancer or not early on because the treatment wasn't so great. The treatment's a bit better now and it might matter more. And so a lot of people kind of go along with it, but you do have to know the insurance coverage can be a little annoying. And I know like it's every year, so it's not just a one-time screening. It's kind of like a mammogram where in order for the screening to be the most impactful, you do have to order them every year so that they're monitoring any changes or any nodules every year. So in our EMR, you can add it to the little reminders for the healthcare maintenance, and it'll flag you every year to remind you to reorder it on patients that you've started the screening on.
Mia, this is Chris. On this case, I would offer one other thing, which is I would go back and find out how that person actually used the medication, because I find often patients don't use meds correctly, and that's the reason why they don't want to go back, or that's why it failed. And sometimes just a second try with a little bit of extra coaching usually is all it takes.
That's a really good point.
The other thing
go ahead.
The other thing I wanted to add is just, Chris, what you were saying before, like this is the perfect time to say most people do not succeed on their first try.
Right.
And I know, so when I went to school, it was back in the late 90s. The statistics then were like the average person try is 7 times before you're successful.
Right.
So I think, again, like reducing the stigma, like making them feel less bad. And obviously right now they probably have more motivation, right? Since they were just in the hospital. So it might be more successful.
Right. Fertile ground. That's such a great point. Thank you. I did not put that in the slides, but most patients, I think you're right. I think the number is still about the same. They try to quit 5 or 6 times before it actually sticks. So it's again another reason to really readdress it with patients. Like I'm always like, hey, how's it going with cigarettes? If they're smoking a pack a day, they'll be like, it's not going so great, doc. But I try to keep bringing it up. And then we have like 2 minutes. Maybe we can just skip to the last slide, Chris. There's just a couple websites that I wanted people to be aware of.
Can I just offer one thing on that last case? I often spend a minute or two really rigorously explaining to them how important it is that they get back on the horse, and how much I will not be disappointed with them, and how much I really want them to call me if it doesn't work, because I really want them to succeed. So I just put a little extra spin on that so that people really understand that they shouldn't be embarrassed. So
yes, yeah, absolutely. And I think again, with this idea of normalizing things, like just checking in about it frequently, and like, oh my gosh, you did so great last year. Oh yeah, I picked up so again. Oh, tell me more about that. What happened? Are you interested in trying again? And a lot of patients are interested in trying again. 2 websites that have a lot of great resources. Hopefully the CDC website will continue to be available to us. But the CDC tobacco has stuff for patients and healthcare professionals. And then this smokefree.gov is pretty cool if you haven't seen it. There's a place in there, it's more for patients, I would say. It's like patient facing. where teenagers can go and enter their cell phone number if they're trying to quit, you know, whatever tobacco product or whatever nicotine product they're using. And it can text, you know, I think it's a bot probably, but it texts back and forth with them. There's also options in Spanish for Spanish speaking patients. I didn't see a lot of other languages, but it's still a pretty cool resource to offer people. And Catherine, you're asking, do we use the same meds for people who vape? Yeah, you can. And I think with the vape is interesting because often the vape liquids have its own nicotine concentration. And so patients can work on a taper off of the vape too. Like they'll tell me, oh, you know, I'm down to the one nicotine or something like that. And I don't always, you know, there's a lot of different products. So I don't always know exactly what product someone's using. But, you know, they can taper, but we can also help them with the gum, with the patches, you know, with the varenicline, because the vape, you know, the substance that is the addictive thing is the nicotine. You know, the cigarettes have all the other bad stuff, but the nicotine is what we're trying to treat with the other products.
Those Stanford resources that I gave the link for are great for converting the smokeless into cigarette equivalents.
Oh,
And
yeah. I've seen this before. Thank you for putting that. Yeah, thank you.
It's just like marijuana, way more potent than the cigarette. Like a Zyn is equivalent. There's 3 milligram and 6 milligram Zyns. So that's equivalent to 3 cigarettes or 6 in one pouch. Yep.
That's a lot.
Mia, could I just offer in the last minute or so just a little bit of how I approach it with patients, especially around getting them mentally prepared to quit. So I spend a lot of time focusing on quit date, and why that's important, because it gives us something that we can focus on and prepare for. And then what I do with that conversation is I say, all right, you've got a quit date. Now you need to tell your friends you're going to quit. Find a friend who already quit, who you're going to call, who's going to remind you why you need to quit when you don't want to quit. I often remind them to make a phone call to the quit line and think about calling it the day they quit. I talk to them about calling their buddy the day they quit and the next day they quit. And then, you know, just anything. And then also about preparing the house, throwing out all the tobacco, all the extra cigarettes, all the ashtrays, all of the lighters, all of the paraphernalia that reminds them to smoke. So I put a lot of energy into that as well.
What about couples? I always say too, if it's a couple, a lot of times I have couples that are they're both my patients, they're both on Suboxone.
Sometimes, Sometimes I say, like, hey, you may not want to do it because they're not going to quit.
Right. You got to get so-and-so on board to help you quit. We got to work on this together.
You really have to collect a lot of collateral information to help these people.
Yeah.
Anyway, thank you so much, Mia. I don't know if we have any additional questions. We can certainly hang out for a minute or two if there are any. If not, thank you all for joining us. Mia, that was wonderful.
Well, thanks.